Welcome to AETCM, the emergency medicine channel. Today we are going to present a case about a 29-year-old female who came to ER with complaints of fever with erythematous rash all over the body since the past 5 days. Shall you, sir? Sir, upon initial 10-second assessment, the patient was conscious, oriented, and was able to speak in full sentence, sir. And airway was patent. There was no pooling of any secretions. In the breathing, air entry was bilaterally equal.
So what all things you look in the oral cavity in a case like this?
So a patient with a rash, we had to check oral cavity for any mucoid ulcer, oral ulcer is there, and you had to check for any in cases of any pharyngeal or tonsillar region, any.
Okay. What are the conditions it will be associated with oral cavity rashes with fever?
Oral cavity rashes with fever can be seen in cases of IMN. Then, if at all given measles, then like drug reactions, erythematous drug reaction, SJS, then 10 also can be there. Then Dress syndrome also can produce the same.
What is hand, foot, mouth disease?
Hand, foot, mouth disease is caused by Coxsackie virus, usually in children of less than 5 years of age. Which
can it come to adult? Can it?
Can occur.
Some patients who relative of that child who develop this hand, foot, mouth disease, they also have same type of disease. In this condition, it is just like a drug reaction. Almost everywhere they can have rash, especially in the palms, oral cavity. That is a classical feature of drug rash. So hand, foot, mouth disease can present just like a drug rash also sometimes. And any other immune-mediated disease can Behcet is single one or two lesions. Which condition you get high degree fever, rash? SLE. SLE is a condition. Behcet disease is one or two ulcers, not rashes.
Okay. Sir, here in breathing, air entry was bilaterally equal. Respiratory rate was 16 per minute with saturation of 95% maintained in the room air. And circulation, BP was 100 over 70 mmHg with pulse rate of 88 per minute, and all peripheral pulses were equally palpable. In disability, her GCS was full score with pupil bilaterally equally reacting, and exposure wise, currently she was not afebrile, she was afebrile. And while doing an exposure, we found that she was having erythematous rash all over the body, and we were able to palpate cervix. Actually, we were able to see also enlarged lymph nodes in the cervical region, sir.
Okay. Which are fevers you get enlarged lymph nodes with rashes? Common things. Don't tell uncommon things. Which is a common condition? You get high degree fever, TB, rash, cervical lymph node in last 2-3 days fever. IMN is the most important condition. IMN or IMN like reaction. There are a lot of viruses including acute HIV can produce acute IMN like reaction. But IMN is the classical condition produced by
Epstein-Barr virus.
Epstein-Barr virus. Parvovirus is common in which condition? Parvovirus produces dash.
Diarrhea.
Parvovirus produces bone marrow suppression in immunocompromised patient. Okay. That also you can get IMN like rashes. Okay.
So here we initially were able to see the rash with the enlarged lymph nodes, sir. So further we did the further systemic examination was normal, sir. No obvious abnormalities was noted. We further send the routine investigations here, sir. And initial point of care CBC was done, and it was showing a initial HB of 11 with the total count of 39,000, and where the differential count was showing a lymphocyte of 53 with the platelet count of 1,97,000. Okay, sir. So further we went ahead with our secondary survey, sir. She was a 29-year-old female with a known case of inflammatory polyarthritis, and
in a patient who is having inflammatory polyarthritis, she comes with high degree fever, rashes. What is the first diagnosis will come to your mind? Fever, high degree fever,
SLE,
rashes, history of inflammatory polyarthritis.
SLE, rheumatoid,
Is inflammatory polyarthritis. That means
flare up,
something like rheumatoid arthritis. She is having high degree fever. She is having rashes all over the body.
drug reaction.
Huh?
Infective development.
Kawasaki is in child. It is a
Still's
different
disease.
Still's disease. Adult onset Still's disease. What is the character of that rash?
Uh,
After fever,
it subsides.
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 so the rashes occur during height of the fever and it disappears when the fever subsides. That is a typical feature of adult onset Still's disease that is classically seen in rheumatoid arthritis or any inflammatory arthritis. Okay, so you should know all these differential diagnosis when you are dealing with a fever with rash, because it is important to know whether it is a viral disease or bacterial disease. If it is viral disease, definitely you are at risk. We have to take care of our like safety.
So here she presented with complaints of erythematous rash with itching and fever with shortness of breath since the last 5 days. So the rash was erythematous maculopapular rash which was found all over the body. And she, there was a history that she started HCQ like 2 months back and sulfasalazine 3 weeks back. And
Can HCQs produce this type of
drug reaction are less in
reaction
HCQ.
should occur in acute phase, and skin rashes unlikely to come in HCQs. Okay.
And for the same she was taken to nearby hospital, and there in which she was evaluated and found out to have lymphadenopathy with lymphocytosis and hepatosplenomegaly. And they did their mono test was done there and which was negative, and ANA immunofluorescence was also done.
Okay.
Report was awaited from that at the point when we got the patients. So further we went ahead with the further blood investigations. In the further investigation, it was found to have she was having SGOT-PT of 114 and 285, sir. And bilirubin also 3.2 with total 3.26 and direct of 2.63, sir. Here creatine was on the normal range 0.6, and we did the peripheral smear, sir. In peripheral smear it was shown as lymphocytic leukocytosis, and we also did the USG abdomen and pelvis was showing hepatosplenomegaly with GB wall edema, and USG neck was showing cervical lymphadenopathy, and axilla was also showing regional lymphadenopathy.
What is the size of the lymph node? That is very important.
Size was more than 2 centimeters size. Okay. And
What it is not a good question for emergency medicine. What is persistent lymphadenopathy? What is lymphadenopathy? What is generalized lymphadenopathy? What is lymphadenopathy?
enlarged lymph nodes.
That is not lymphadenopathy. Size is very important. Size more than 0.5 in all other areas other than inguinal area. That is lymphadenopathy. What is generalized lymphadenopathy? More than 2 contagious sites. Contagious sites means one is, if it is in the mediastinum, it can definitely come to the cervical area. Suppose it is in the mediastinum and below diaphragm one area is there, then it is generalized lymphadenopathy. Persistent, more than 3 weeks. You can just remember 3 weeks or 3 months. 3, 2, 1. 3 months, 2 areas, 1 centimeter. Okay, so if you can remember like that, that will be enough. Okay, persistent generalized lymphadenopathy is a feature of which all diseases? Persistent generalized lymphadenopathy.
Lymphoma.
TB and lymphoma and HIV. Okay.
And here we also did the IgM EBV test, sir. It was negative, and absolute eosinophil count was also done. It was also normal, so 1.1 only.
Okay.
So and we started here on initially steroids, sir.
What is your diagnosis in this patient?
So for the same, she was having fever with rashes and also lymphadenopathy, And as the rash developed actually by the after 3 weeks of starting sulfasalazine, we were suspecting initial diagnosis of DRUS syndrome, sir.
The syndrome you need to have eosinophil count high. That is not there. So DRUS syndrome is only when you can diagnose drug-related rash with eosinophilia. That is, eosinophil count is not elevated here. Okay. So that is out.
Initially, it was the diagnosis. We also thinking of other diagnoses like hypersensitivity drugs, drug reaction to drug hypersensitivity.
Normally,
reaction.
after 3 weeks, it will not produce any drug rash, but it can happen. Okay. The problem is when you are starting one drug and you add another drug to the regime, if there is a drug interaction, that also can produce rashes. Especially hydroxychloroquine is known for that. If you add some other drug to hydroxychloroquine regime, then there can be drug interaction and drug reaction. Okay, so that is also possible. But when in normal clinical practice, after 3 weeks, developing a skin rash due to sulfasalazine is not a common thing. Okay, but here we have a patient who is having high degree fever. He is having generalized rashes, including palms and lymphadenopathy. You can suspect viral
SJS10 and viral
infection. That is the most common thing. And there are some viral infections, they can include rashes, oral cavity, palms, everywhere. But unfortunately, we cannot do testing for all these viruses, because if you are doing tests for all these viruses, the cost of the treatment will be very high. And most of these viral infections are self-limiting. There is no need of major drug therapy for them. So sometimes we will not get any diagnosis. Only thing what we have to rule out is these lymph nodes are persisting or not. We have to find out. If it is persisting, then we have to do investigation like HIV and all. Okay, can HIV produce an acute HIV infection? Can they present like this?
Yes.
Acute HIV conversion is like this. They have rashes all over the body, high degree fever, lymphadenopathy. But during that time, we never suspect HIV, and after sometimes if we check it, it will be positive. So that also should be checked if you have a strong suspicion.
We have sent the pre-op also, sir, and HIV was negative. And we also initially thought of other differential diagnoses like cutaneous T-cell lymphomas,
Okay,
and SLE flare-up. And by that time, we got the ANA report, sir, and it was negative.
Okay.
And then the other differential diagnosis into hypereosinophilic syndrome was also ruled out because as eosinophil counts were low. Then other one was SJS or 10, sir.
Okay. A possibility of drug reaction here is it's less important, because the time period between the rashes to the drug, so that is 3 weeks. So unlikely that this is a drug related thing. It can be mostly viral infection.
And here we initially started here on steroids with steroids, and we also consulted dermatology and rheumatology for the same, sir. And after starting steroids, her LFT was downtrending, and also she was becoming better. Except initial stages, she was having mild breathing difficulty, and O2 support was needed, and which was later tapered and stopped, sir.
Okay.
And
if it is a drug rash, how do you treat? If it is, suppose you have a strong suspicion of drug-related rash or anaphylaxis, something like that, how do you treat?
For anaphylaxis, we had to give the patient adrenaline 0.5 ml IM adrenaline 1 in 1000 have to be given, sir. For if at all the patient is not in any anaphylaxis, we can.
No, what are the other drugs? Adrenaline 0.1 ml 1 in 1000 IM should be given. Next is
we have to give steroids. Hydrocortisone can be given, sir, and we have to give antihistamines,
H1 and H2 blockers. See, these 4 drugs has to be given for all patients. Adrenaline is given for acute problem. Steroids are given to prevent further problem. And H1, H2 also should be given. Okay. In Stevens-Johnson syndrome or other condition, how do we manage the patient?
In Stevens-Johnson syndrome, we should not give the steroids, sir. We should withhold the drugs which have caused the same, and we have to start the patient on cyclosporin or plasma exchange can be done.
Okay.
Other thing that we can do is that we can use
What are the
dialysis, cytosol.
complications? Cytosol can. What are the complications these patients can develop? This STN, Steven Johnson syndrome can develop.
Cytokine storm can occur. Then patient can like as the skin will be totally avulsed or removed, patient can develop secondary skin infection can be there, and patient can have like dehydration, dyselectrolytemia due to the skin loss. You have to
So
correct
it should
the
be treated something like burns. So skin is the most important protective organ in our body. So once the skin is disrupted, then patient can develop any sort of infection, and they can have oral cavity ulcers, esophageal ulcers. So you have to continuously give fluids throughout the treatment, and sometimes albumin can be very low. That has to be corrected. Antibiotics should be given to prevent skin infection. What antibiotic will give to prevent skin infection?
gram positive or
Which are the antibiotics we can select?
um,
Augmentin.
cephalosporins also can.
First generation cephalosporin, amoxicillin, clavulanic acid, azithromycin, all can be given. Okay.
Sir, this patient after the initial breathing difficulty, patient improved and his hair like LFT also became normal, and as the ANA report was also negative, and patient's facial edema and as well as the regional lymphnopathy was present actually, but the other symptoms reduced, and we discharged her with in oral steroids,
Okay.
which in tapering dose, and asked her to
Can you get oral sore throat, oral throat pain, lymphadenopathy in adult onset Still's disease? Can you get? It is known. See, most of the adult onset Still's disease present like infectious mononucleosis. Those who have already a joint pain, history of rheumatoid arthritis, they present with high degree fever, sore throat, lymphadenopathy, generalized rashes, that present as an acute condition. So, if the rashes are persisting after steroid or after subsiding of fever, then diagnosis is different. It's a viral infection or infectious mononucleosis like syndrome. Otherwise, we have to strongly consider this as a adult onset Still's disease, a part of immunological disorder. That's why this patient has significantly improved after steroids. Even viral fever also will improve with steroids. They are not the treatment. They improve, symptomatically improve with steroids. Okay. Anything else you want to add? Nothing.
Sir, other like the drugs which usually cause the syndrome, sir. So we have like high risk group and low risk group. High risk group include allopurinol, then the anti-epileptics like phenytoin, carbamazepine, oscarbazepine, lamotrigine, then sulfonamides, sulfasalazine, dapsone, cotrimazole. Then we have vancomycin, minocycline, and in low risk group we have beta-lactam, NSAIDs with olanzapine also can cause the same, sir.
So beta-lactam antibiotic, many patients are documented as beta-lactam allergy as actually they are not allergic. It is falsely diagnosed or falsely written as penicillin allergy. So if you properly do a testing, then you can understand that most of the patients who is having penicillin allergy may not have actual penicillin allergy. Okay. Okay.